Για αυτούς που μου γνωρίζετε, ξέρετε πως δίνω τις ομιλίες μου στα αγγλικά και κάνουμε τη συζήτηση στα ελληνικά. This is a very timely topic, whether we should be using shorter courses of therapy to treat common pediatric infections. And there's a lot of data coming out recently about this. By way of overview, I'm going to talk a little bit about the history. Everybody's been talking about history today. And then we're going to talk about shorter courses of therapy for common pediatric infections. We're going to talk about urinary tract infections, community-acquired pneumonia, bone and joint infections very briefly, and otitis media. So one of the things we've been teaching as pediatricians, but not just pediatricians have been teaching, is the WHO, the CDC, and everybody has been saying, always take the full prescription, even if you feel better. And I'm going to challenge that maybe we've been saying the wrong thing. Maybe we should stop taking our antibiotic therapy when we feel better. And some of the studies that I'll show you actually tested that hypothesis. This is the tradition that I just mentioned. Physicians and public health officials advocate that we complete our full course of antibiotics. In truth, treating bacterial infections for only as long as necessary is the safest way of reducing unnecessary antibiotic use. We spend a lot of time arguing, should we start antibiotics, should we stop antibiotics? But one of the easiest targets in antibiotic stewardship is to reduce how much antibiotics we use. Stopping treatment when symptoms resolve. The duration of antibiotic therapy that we currently use for most infections is based on the fact that the week has 7 days. That's how we decided this. The modern week has 7 days because the Roman Emperor Constantine the Great declared it in 321 BC. Had he chosen a 4-day week, we would be prescribing 4 or 8 days instead of 7 or 14 days. There are 40 randomized clinical trials in the past 25 years comparing shorter courses versus traditional courses of antibiotics. That is more randomized clinical trials than many other diseases in medicine. In every single one, and I'll show you the data in a minute, shorter courses of therapy were just as effective and associated with fewer adverse events or diminished emergence of resistance. Patients who received longer courses had significantly more adverse effects, and the risk for an adverse effect increased by an alarming 5% for each additional day of antibiotic therapy. Community-acquired pneumonia, short course versus long course, hospital-acquired pneumonia, complicated UTI pyelonephritis, intra-abdominal infections, gram-negative bacteremia, chronic bronchitis, skin and soft tissue infections, chronic osteomyelitis, and empiric neutropenic fever. These are short course versus long course, and none of these found significant differences between those two groups. So let's start with urinary tract infections. The American Academy of Pediatrics national guidelines recommend treating children with pyelonephritis for 7 to 14 days. Yet data are lacking to suggest a more precise treatment. When somebody says 7 to 14, to me, that is not a reasonable range. If you could treat somebody for 7 days, why treat them for 14 days? That's a weak difference in antibiotic therapy. This is a study published in 2020 looking at the comparative effectiveness of antibiotic treatment duration in children with pyelonephritis. They compared short course to long course. This was not randomized. And short course was about a week. Long course was about 10 or 11 days. Most people, this is what they saw in the study. Most people treat either 10 to 11 or 7 or 8 days. So intuitively, we choose a week or 10 days if left to our devices. And when you compared the short course to the long course, whether we use the first generation cephalosporin, broader spectrum cephalosporins, trimethoprim sulfur, or fluoroquinolones, there was no difference in the outcome if you got about a week or 10 days. This is the SCOUT trial that I was involved with in the United States, looking at short course therapy for UTIs. This randomized about 700 children to short course or long course. Short course was 5 days. Long course was 10 days. Standard course was 10 days. And in this study, the randomization occurred if they were getting better. So if the child on day 5 was getting better, we said stop antibiotics and get placebo or continue antibiotics. So the test was not from day 1, was at day 5, if they actually day 3 to 5, if they were getting better. And the standard course, which is 10 days, the failure rate was 0.6%, and then the short course arm was 4.2%. In terms of adverse events, no significant difference in adverse events between the short course and long course therapy arm. So I'm going to go back to this. This result has created a lot of conversation and a lot of discussion. The study was set up to be a non-inferiority study so that the two groups were found not to be equal. And truth, they were found not to be equal. Statistically, one was not found to be greater than the other, but they were found not to be equal. If you look at the glass half full, you say that more than 95% of the children will not relapse, regardless of whether they get 5 days or 10 days. If you look at the glass half empty, you say, well, there's a difference here, 5% versus about 1% or 0.5%. The number needed to treat, if you treated, you would need to treat 27 more kids with long course therapy to prevent 1 recurrent infections. And that left the pediatric community very mixed about what they should do with this result. This is a systematic review of short IV courses for UTIs in young infants. This is another common question when I'm at Aglaia Kyriakou seeing patients is how long do we treat IV for UTI in the hospital? There's 18 studies with 16,000 infants, so a very large sample size. The largest studies on bacteremic UTI found no difference at 30-day recurrence between those who got less than a week of IV and those who got more than a week of IV. In non-bacteremic UTI, children who did not have bacteremia with their UTI, there was no difference in 30-day recurrence between those who got less than or equal to 3 days or greater than 3 days. So how many of us who see patients in the hospital treat for more than 3 days of IV? I think most of us do. 3 studies of infants aged 30 days or older used oral antibiotics alone and reported good outcomes. So no IV at all. Shorter IV antibiotic courses of less than 7 days and less than 3 days with early switch to oral should be considered in infants aged less than 90 days with a bacteremic and non-bacteremic UTI, excluding anybody who has suspicion of meningitis. Another study looking at the same question, parental antibiotic therapy duration in young infants with bacteremic UTI. Multi-center retrospective cohort study, infants less than 2 months of age who had the same pathogen grow in the blood and the urine at 11 children's hospitals in the United States. Short course was less than a week, long course was greater than a week. There was no significant difference in the 30-day UTI recurrence between the long and short course therapy. Let's switch to community-acquired pneumonia. I think you heard already some comments about this. This is the SCOUT CAP trial, short course versus standard course outpatient antibiotic therapy for community-acquired pneumonia. This was done in the United States. The short course arm was 5 days. The long course arm was 10 days. The clinician decided to use amoxicillin, amoxiclavulinate, or ceftonir to treat the infection. There was about 189 patients in the short course arm and 191 in the long course arm. And inadequate clinical response was in 2 patients in the short course arm and 1 patient in the long course arm. So almost nobody failed, and it had nothing to do with whether they got 5 days or 10 days. And no significant difference in any of the other outcomes they looked at in terms of antibiotic effects, side effects, etc. The UK tried to address this question in their own large trial. This is the CAPIT randomized trial from Julia Bilecki and her colleagues in the UK. They randomized 824 patients to 4 different groups. So they looked at low dose amoxicillin, 30 to 50 milligrams per kilo, high dose amoxicillin, 70 to 90. Because there's this question, should we be giving higher doses of amoxicillin for community-acquired pneumonia? And then short duration, 3 days, or long duration, 7 days. Absolutely no difference. 12%, 12%, 12%, and 12%. The median age of the kids in these in the study was 2.5 years, so young kids with pneumonia. So no difference whether you use a low dose of amox, a high dose of amox, or give 3 days or 7 days. And very large study, 421 boys and 300, so about 800 patients. One of the questions that the investigators anticipated was, since pneumococcus is the organism we treat in community-acquired pneumonia in children, was there any relationship between the MIC of the pneumococcus and whether you got the 30 to 50 dose or the 70 to 90 dose? And there was no difference. So the resistance patterns, or the penicillin MIC of the pneumococcus, did not predict failure if you gave lower doses of amoxicillin. I just want to point something out here, just one piece of data on this, which looked at the amoxicillin duration. In terms of adherence to all the doses, if you look at adherence, it was 94% in the 3-day arm and 79% in the 7-day arm. So even when we do prescribe longer courses of therapy, the patients don't take them to the extent that we prescribe them. So 2 out of every 10 kids didn't adhere to the antibiotic therapy in the long course arm, which was only 7 days, not longer. 2 large meta-analyses looking at this question of short versus long course antibiotics in community-acquired pneumonia in kids. Again, this meta-analysis of 1, 2, 3, 4, 5 trials, no difference between short course and long course. Same here, no difference between short course and long course. In subgroup analyses, because I know these are the kinds of questions that I get asked at these, did it matter the age of the child? Did it matter how it was diagnosed, x-ray or clinically? Did it matter if which antibiotic they used or the dose of antibiotics? And none of that seemed to matter in terms of whether short course was as effective as long course. Antibiotic treatment, another study again, this is 2 years ago in 2023, similar results. The triangle suggests no difference in short course or long course in terms of need for hospitalization, treatment failure in the second one, and includes both in the third one. Okay, ESPID is about to come out with the guidelines that you have all been waiting for. I know δεν κοιμόσαστε καθόλου αναμένοντας αυτές τις οδηγίες. I'm going to give you, I can't give you the whole guideline. It's not published yet, but I'm going to give you several of the highlights that, with respect to treatment duration. So for the first time, there's a guideline, and Nikos Spiridis will be very, very happy with this, that withholding antibiotics and adopting a watchful waiting approach may be appropriate in previously healthy children with non-severe community-acquired pneumonia, provided that the child can be monitored and reevaluated if they get worse. How do you feel about not treating community-acquired pneumonia? Sì, όχι, then. Why? But let's think about this before we laugh it off. One of the hypotheses on why duration or dose doesn't matter is that we're not treating bacterial pneumonia. Most children age 2.5, which were the children in the CAPID trial, have viral pneumonia. So we're treating all these kids with viral pneumonia, and I think the guideline committee, after reviewing all the data, said it's probably safe if you can really follow up the child carefully, since most of them have viral pneumonia that you don't need to treat. Okay, since I know all of us are going to treat, as an outpatient, oral amoxicillin at 80 to 90 for 5 days. So now we're down to 5 days is recommended as first-line therapy for previously healthy children. In the hospital, penicillin G, ampicillin for 5 to 7 days. Yeah? Good. NICE, which is the agency in the UK that puts out guidelines, actually took it a step further. They just published this. What was interesting, it came out as if we were writing the CAP ESPID guidelines. And they said this, 3 days. So the UK NICE organization, which is the quality guideline committee organization, said 3 days of antibiotics. Very quickly, just a few words about bone and joint infections, because this is another infection that traditionally we've been treating for weeks and weeks and weeks and months. This is practice guideline. 2 practice guidelines were published, one by ESPID and one by PIDS, the US Society. And the minimum duration of antibiotic therapy for osteomyelitis should be 3 to 4 weeks, and for septic arthritis, 2 to 3 weeks. Level 1 evidence. It was the top level evidence for the duration of therapy for septic arthritis and osteomyelitis. However, there are now studies and data coming out that we probably can even go shorter. This is a study looking at 10 days versus 30 days for septic arthritis, 10 days, 30 days. And there was no treatment failures, almost no treatment failures in either of those arms. So maybe eventually we will get to even shorter courses of therapy for these infections. Otitis media. This is now the well-known Hoberman study published in New England Journal of Medicine in 2016. They looked at short course 5 days versus 10 days for otitis media, and they found a significant difference that there were higher treatment failures in the 5-day versus the 10-day group. So in the 5-day, 34% treatment failure. In the 10-day group, 16%. So about double the rate of treatment failures. Why is that? Why otitis media? We can treat kids with urinary tract infections shorter. We can treat patients with community-acquired pneumonia shorter. Probably because otitis media, just a hypothesis, is an abscess. It's a closed space that has an infection. Although that, I don't think anybody's proven that, but it's a hypothesis about why for otitis media that is the case. So some of my colleagues here said that you should call the infectious disease doctors when you have questions about durations of therapy. So my question is, are infectious disease specialists recommending short antibiotic treatment durations? An estimated survey said that found that only 1 of 3 ID specialists recommend short course therapy across many countries in the European Union. And the rate is likely lower if you think infectious disease practitioners are not prescribing short course. What are other practitioners who are not infectious disease experts prescribing? Are we older and wiser? Does wisdom come with age? Early career physicians, 11 years since graduation, are significantly less likely to prescribe long courses of antibiotic therapy than mid-career or late career physicians. Late career physicians, greater than 25 years since graduation, perform the worst in terms of durations of therapy. And we should really focus antibiotic stewardship education on medical students and residents. So to conclude, shorter is better. Short course antibiotic therapies have been shown to be just as effective as longer courses for a variety of bacterial infections. And we need to talk a little bit about culture and philosophy. Change is scary, and medicine is a very conservative profession. We're all afraid. The core ethos of our profession is based on an oath that is 3 millennia old, and we should uphold that oath. To live up to the expectations that our patients have for us and that we have for one another, we must overcome our inertia and tradition and change practice when compelling evidence exists. Thank you very much.